Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 247 of our pharmacotherapy series, which majors in infectious diarrhea. The next question reads, FTF is a 30-year-old, previously healthy woman, presenting to her physician with non-bloody, watery diarrhea of 3 days duration. Her history of present illness is significant for the following. 2 days before the onset of her gastrointestinal symptoms, she visited with her 4-year-old nephew in California who was recovering from an intestinal illness caused by Shigellasis acquired at his day care center. FTF has no significant medical history. Overall, she feels better compared to the previous day and is afebrile. How does FTF's clinical presentation of Shigellasis differ from that of MOT in the previous case? Should FTF be treated with antimicrobials for her presumed mild case of Shigellasis? Let's briefly discuss the treatment of Shigellasis in this case. Compared to MOT, FTF is experiencing a much milder, and likely self-limiting case of Shigellasis. In industrialized countries, risk factors for Shigellasis include settings where individuals are in close contact, such as in child care centers, military barracks, and institutional housing. International travel and sexual transmission in men who have sex with men are other means of spreading Shigellasis. Secondary attack rates as high as 40% occur within 1 to 4 days after exposure to the primary case. Infected persons may continue to asymptomatically shed Shigella in stool following recovery from their illness. Shigellasis accounts for 90% of Shigellasis in developed countries. As most patients have a mild and self-limiting illness, antimicrobials are not generally required. However, from a public health standpoint, they are often prescribed to shorten the duration of illness to reduce the infectious period. On the other hand, with the emergence of multidrug-resistant Shigella species, some experts favor reserving antimicrobials for only severely ill persons. Empiric antimicrobial options include a 3-day course of either ciprofloxacin 500 mg orally twice daily or azithromycin 500 mg orally once daily. Ceftriaxone can also be used. Clinical improvement may be evident within 24 hours. We will briefly discuss the prevention of Shigellasis. Prevention of Shigellasis requires good hygiene, including proper hand washing and reducing fecal-oral exposure during sexual contact. Development of an effective vaccine has been limited by poor vaccine immunogenicity, decreased vaccine protection because of the changing prevalence of infection caused by non-vaccine serotypes, and adverse effects. The next question reads, MKU is a 20-year-old, previously healthy woman presenting to the Student Health Center with the following complaints for the past 24 hours. Malaise, fever, diarrhea, abdominal pain, and bloody diarrhea. 1 day before the onset of symptoms, she dined at a restaurant near campus, noting that the chicken she ate was not thoroughly cooked. She has no significant medical history, no recent travel history, and is a full-time student at a university in the United States. On physical examination, MKU is not ill-appearing. The physician tells her that during the past week several students with gastrointestinal symptoms similar to hers have been diagnosed with Campylobacter jejuni gastroenteritis, and all had recently eaten at the same restaurant. So my question to you is, why is MKU's history of present illness and clinical presentation consistent with Campylobacter gastroenteritis? MKU's presumptive diagnosis of Campylobacter gastroenteritis is consistent with her recent history of eating undercooked chicken at a restaurant associated with an ongoing outbreak of Campylobacter gastroenteritis. In industrialized nations, the most important risk factor for acquiring Campylobacter infection is the consumption of contaminated undercooked poultry, dairy products, unpasteurized foods, or contaminated water. Prevention of Campylobacter infection involves careful food preparation and cooking practices. Beginning 24 to 72 hours after consumption of contaminated foods, clinical manifestations of Campylobacter gastroenteritis typically include diarrhea, fever, and abdominal cramps with either loose and watery or bloody stools. Post-infectious complications of Campylobacter jejuni gastroenteritis include Guillain-Barré syndrome, reactive arthritis, and post-infectious irritable bowel syndrome, the latter associated with diarrhea lasting more than 7 days. The next question reads, would MKU benefit from antimicrobial therapy to treat her Campylobacter gastroenteritis? Because Campylobacter jejuni gastroenteritis is typically an acute, self-limiting illness resolving within 3 to 7 days, antibiotic therapy is usually not necessary. Antibiotics are recommended for patients with symptoms lasting longer than 1 week, high fevers, bloody stools, pregnant women, or immunocompromised hosts. As MKU's clinical presentation includes fever with bloody stools, antimicrobial therapy is warranted. Effective antimicrobial therapy shortens the duration and the severity of illness by a mean of 1.3 days, and it is most beneficial when started with 3 days of the onset of illness. The next question reads, what empiric antimicrobial therapies could be initiated to treat MKU's presumed case of Campylobacter jejuni gastroenteritis? We will now discuss macrolides and azalides. Macrolides, or an azalide, remain the drugs of choice for the treatment of Campylobacter gastroenteritis. Macrolide resistance has remained relatively stable around 5%, but depending on geographic location, higher macrolide resistance has been reported from Eastern Europe and China, 5% to 11%, and India, 22%. Next we will look at fluoroquinolones. Once considered the drugs of choice for Campylobacter infection, fluoroquinolones are no longer first-line options as a consequence of widespread fluoroquinolone resistance, largely attributed to their use in veterinary medicine and food animals, e.g., poultry. The latter practice has since been banned in the United States. Fluoroquinolone-resistant Campylobacter jejuni exceeds 80% in Spain, Thailand, and Hong Kong, and it is about 50% in selected European Union states. In the United States, the prevalence of ciprofloxacin-resistant Campylobacter jejuni remained between 20% and 30% from 2007 to 2011. However, higher quinolone resistance among Campylobacter isolates in international travelers returning to the United States compared to non-travel associated isolates, 60% versus 13%, underscores the need to consider local resistance patterns from where infection was acquired, when selecting empiric antimicrobial therapy for returning travelers. Recommended oral treatments for Campylobacter jejuni gastroenteritis for adults are azithromycin 500 mg once daily for 3 days or erythromycin 500 mg 4 times daily for 5 days. Children may be treated with azithromycin 10 mg per kilogram per day once daily for 3 to 5 days or erythromycin 30 mg per kilogram in 2 to 4 divided doses for 3 to 5 days. On the basis of MKU's medical history and clinical presentation, empiric therapy with oral azithromycin can be started. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 248.